Dr. Dave Gutton will be talking about up, and away, recurrent DVDs, the management of them surgically.
Okay, thank you very much, Jeff. On financial disclosures, I have some non-money making patents on ophthalmic instruments, but nothing relative to this talk. The official title is Up and Away, Recurrent Dissociated Deviations, but that's my particular title is The Management of Recurrent DVD After Previous Surgery for DVD. Now, it's necessary to go back and briefly explore and review what we found out about 20 years ago regarding the cause and mechanism of DVD. First, there's incomplete development of binocular vision in infancy. Latent nystagmus then develops a horizontal component which decreases vision, and a cyclovertical component which also decreases vision. Now, to improve vision, many patients unconsciously learn to converge to damp the horizontal component of the latent nystagmus. Now, we call that DHD. And that's been a little confusing because that was initially confused because there was a divergence component when the convergence relaxed that people thought was an active divergence movement, which is not, because when XT is present, that's what you see in these patients. But the damping vergence is always a convergence. And if you have an asymmetrical response to the two eyes, you see it. If it's symmetrical, you just say it's intermittent tropia. So it's very confusing. You have to have an asymmetry in the dissociated horizontal to even see it in the first place. And then further, also to improve vision, many patients unconsciously learn to make complicated cyclovertical movements to damp the cyclovertical component of the latent nystagmus, and that's what we call DVD. The movements that are used are a vertical vergence / cycloversion that's mediated by the superior oblique muscle in the fixing eye and the inferior oblique muscle in the non-fixing eye. But you can't let the fixing eye go off target, so you have to add an upward version to maintain fixation. So each movement that's involved here in DVD does obey Hering's law, but the composite movement does not seem to. This is an example of the eye movement recordings we made with scleral search coils back 20 years ago to figure all these things out about dissociated deviations. For example, if you suddenly occlude the non-fixing left eye, you see all this latent nystagmus that develops right then, hadn't done before, and develops right then, and that decreases vision. So what happens is the left eye shoots upward. That's the DVD movement, the left eye going upward. That's the part of the vertical vergence that damps the latent nystagmus. Here the left eye is adducting, part of the convergence that's damping the horizontal component of the latent nystagmus, and the left eye also intorts. That's part of the cycloversion movement that we see. So with this sort of tracing, we could figure these things out. Over about 2 seconds in this case, notice how the latent nystagmus damps beautifully to improve the vision. And I have one eye up that's non-fixing. The fixing eye is on the baseline, the right eye, the warm colors, and that's the one that has the better vision because of this. So to review, what are the primary muscles involved in DVD? In the fixing eye, the superior oblique muscle tries to depress the eye. The superior rectus muscle elevates it to keep fixation constant, and there's no net vertical movement. In the non-fixing eye, the inferior oblique muscle elevates the eye, and also the superior rectus muscle, because of the version movement that to keep fixation okay, that elevates the eye as well, so we get a net upward movement of the non-fixing eye that we call DVD. So what are possible surgical strategies? I would love to have a way to eliminate the latent nystagmus. We'd solve the whole problem. But how? There's no known way to surgically eliminate latent nystagmus. We can weaken muscles, we can create restrictions, we can transpose muscle attachments to alter the muscle's mode of action. What are the common initial ways that we'd use to treat DVD? First, bilateral superior rectus muscle recessions, 8 to 14 millimeters. Asymmetric if the DVD is asymmetric. We can add inferior oblique muscle weakening if there's a V pattern present, or we can add superior oblique weakening if a moderate to large A pattern is present. When making these large recessions, I like hangback techniques where you measure the amount of recession you want with the muscle pulled up against the original insertion site, and then let it go back to hang back to the usual, wherever you wish to use it. That's the bilateral superior rectus recessions. That, to me, is the most common thing and what I do most of the time. Many people, though, like bilateral inferior oblique anterior transpositions, especially if a V pattern is present. And there's some less common initial surgeries as well, such as bilateral superior rectus muscle posterior fixation procedures, 12 to 16 millimeters posterior to the limbus, or bilateral inferior rectus muscle resections. We'll see what's wrong with each of these in a little bit. And then 4 oblique muscle weakening procedures, sometimes used to avoid anterior segment ischemia if recess-resect procedures have already been done. So this is the first audience response question we have of this morning, it appears. If you have your devices ready to vote, I want you to vote on this. Which procedure do you most commonly use initially for bilateral DVD? Number 1, superior rectus muscle recessions. Number 2, inferior oblique anterior transpositions only if a V pattern is present. Number 3, inferior oblique anterior transpositions even without a V pattern. Number 4, superior rectus posterior fixation procedures. And number 5, inferior rectus muscle resections. So please do vote. And I'm going to get my camera out and take a picture of this because I'd like to know this too. What you most likely do.
Dun, 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 dun.
We've got 10 seconds, and please do vote. Let's see what happens. I don't know when the 10 seconds is up. It looks like we're pretty stabilized. So most people do this bilateral superior rectus recessions. And the least, and I listed them in order that I thought it would be, and that's what it turned out. Okay, so let's move ahead. And I don't know how to move ahead because my button is not responding. There we go. So what are the problems with these initial surgeries with bilateral superior rectus muscle recessions of 8 to 14 millimeters? We sometimes get asymmetric results. For example, in this young man who already had a left DVD much greater than the right DVD, had asymmetric surgery, the right superior rectus muscle recessed 7 millimeters and the left recessed 11 millimeters, still has an asymmetric result. For the left eye, have to do something else. So this asymmetry plagues us sometimes with just plain superior rectus muscle recessions. And there's also the upper lid elevation that can happen with these procedures as well, depending somewhat about how far you dissect backward, but otherwise you really can't tell for sure. This young lady is going to have bilateral 12 millimeter recessions of her superior rectus muscles. Look at the upper lids. This is before surgery, this is after surgery. They did elevate, not objectionably in this case, but other cases objectionably. This case says patient has esotropia and bilateral DVD beforehand, and did bilateral medial rectus muscle recessions and bilateral superior rectus recessions, and now he has the stare effect, which we really don't want to get. Even with a small bilateral superior rectus recessions, when you weaken both elevators of both eyes. And other problems, what about bilateral inferior oblique anterior transpositions? What problems do we get there sometimes? Occasionally asymmetric result. There's a risk of anti-elevation syndrome, and we should learn to attach the disinserted inferior oblique muscle right at the very corner of the lateral rectus muscle, not resect it, right at the very corner, and don't put it temporally because you're likely to get the anti-elevation syndrome there. And we certainly get elevation of the lower lids here, and that's one reason I rarely use this procedure anymore because of that. This girl had a unilateral anterior transposition of the inferior oblique muscle on her left eye by somebody else, and in upgaze, the right eye is normal. That's how the eye should look in upgaze, but in the left eye, you see the lower lid coming up with the left eye, giving this weird appearance. So you certainly do get some lid elevation, especially in upgaze with these problems. And then you worry about the long-term development of A patterns. Okay, if you don't have a V pattern to start with when you do inferior oblique procedures. And long-term development of inverted Brown pattern. We find that over many years, when you do these stems as long as I have, you start seeing patients come back with a tight inferior oblique muscle, and the eye won't go down and in. You have to weaken it further to make it go down and in. It's like an inverted Brown pattern. What about superior rectus posterior fixation procedures? 12 to 16 millimeters posterior to the limbus. Well, that's surgically difficult in the first place, and it's theoretically not effective. Because after all, the posterior fixation procedure was devised to limit the movement of an eye in its field of action, not to return the eye to midline. It just limits it. It won't go as far up or down, but it won't bring it back midline. So why this procedure was ever thought to be used for DVD, I don't know. In bilateral inferior rectus resections, the problems there are elevation of the lower lids especially, and then a recurrence of the DVD, because when you do resections without opposing weakening muscles of the other side, you get a wearing off of 30 to 50% over the first couple of weeks or couple of months, and get a recurrence of the DVD. This patient had previous bilateral medial rectus muscle recessions, has residual esotropy as well as DVD, had underwent bilateral inferior oblique weakening, some more medial rectus recession, and some lower lid advancements, resections, 11 millimeters on the right and 7.5 on the left, and has nice straight eyes, but look at those terrible lower lids. I really don't like inferior rectus resections because of that. She had a resect procedure, another person, on the right eye for large DVD and just a superior rectus recession on the left eye. But look at the asymmetry of the lower lids. On the type that had the inferior rectus resection, you see the lower lid high on the right, which gives a very disturbing appearance. So what about the foreoblique muscle weakening procedure? When I just was investigating the cause of DVD 20 years ago, I recommended this procedure, but never investigated it myself. But in South America, it was investigated by Susana Gamio in Buenos Aires and by Fernanda Krieger in Sao Paulo. And they found you got an average of about 60% reduction in DVD for the amount of weakening they were doing. Useful only in symmetric cases because it's symmetrical surgery that they taught. So when an overcorrection or recurrence occurs, look for this: restrictions, overactions, underactions, new onset A or B pattern, asymmetries and misalignment, lid fissures or fixation behavior. Look at fundus torsion. It should not be there in pure DVD. If you do have it, you have oblique muscle problems to deal with. Look for anomalous head postures. Usually in these associated deviations, these are used to damp the nystagmus, not to achieve alignment. So then they persist when you cover the non-fixing eye. So you must include surgery in the fixing eye if you want to hope to improve the head posture. Lancaster-Ray-Green test must be helpful, and with each eye fixing as well. So what are the strategies? Basic strategies: if overcorrection, move the overcorrecting muscle back toward its origin. If undercorrection, do more of the same surgery, makes sense. If a new deviation, consider operation of the muscles, and use adjustable sutures if possible, but fixation effort is not as intense the afternoon of surgery, and residual DVD may still be missed. So some specific operations in bilateral superior rectus muscle recession. If asymmetric result, do more recession on the higher eye or advance the superior rectus on the lower eye. If large superior rectus muscle recessions, if symmetric undercorrection, add inferior oblique myectomies, but small amounts, not large amounts, to avoid the limited elevation, the stare effect. This young man had both inferior obliques operated on and superior rectus muscles, small amounts, and still comes back this way. And it doesn't always go away. It still looks like somebody caught him with his pants down. With inferior oblique anterior transpositions, here we go. If there's persistent DVD post-op, do judicious superior rectus recessions on adjustable sutures if possible, but you can still get overcorrections from all four elevators being weakened. With inferior oblique anterior transpositions, if there's an overcorrection post-op, consider an inferior oblique myectomy on the lower eye. And finally, with bilateral posterior fixation procedures, if an asymmetric hyperdeviation post-op, asymmetric, consider an inferior oblique myectomy on the higher eye, and inferior rectus muscle resections, for overcorrection post-op. Loosen inferior rectus muscle because that helps correct lower lid as well. So if this is your next patient with bilateral DVD worse on the left, with an A pattern, do bilateral superior oblique tenotomies and asymmetric superior rectus recession, 7 on the right and 11 on the left, and you may get a very beautiful result such as this. And be greeted by this warm and gratifying smile on the post-op exam. So if you choose the right procedure, DVD surgery can certainly work beautifully sometimes. Thanks very much.